Much delay. We had two presentations. We are moving to the animation part. So today we have a lot of presentations, but a crowded slide is something that I personally don't like. I like to keep my slides in a very moving format. So how to make a 2D and 3D animation is what I'm going to cover in the next few minutes. So you can see I start with an animation of an angle recess here. So this is an animation of an angle recess. An animation really gives lot of cognitive detailing to the users. So we have our own YouTube channel. It goes under my name Prasanna Venkatesh Ramesh. You can at any point in time do visit all the animation bouquet that is there in my YouTube channel. And to start the PPT, I would like to show you this one animation, a glaucomatous cupping with notch. The whole glaucomatous process you can see has been summarized in a single animation. First we show the fundus, then we show the animation of how the cup disc ratio is enhanced by showing how in between we have a vertical line. Then I'm showing the inferior notch here as to how the notching happens. And then we zoom in further and we show what is a bionetting sign. And then we zoom in more further and show ISNT rule is breached. So then we kind of zoom out and we show the RNFL defects here. We map a special color for it. Then we go on top and show how it corresponds to a superior arcuate scotoma. And then we come out and then we summarize with a ganglion cell layer defect. As you can see here, there is a mild ganglion cell defect corresponding to that inferior RNFL and summarizing the focal points. So in 1 minute, if somebody asks me, can you summarize a glaucoma defect? So that is where we are moving towards today. So we show an animation and then we show the focal points. So then we give a good take home message to the users, especially in YouTube or in Instagram Reels. So these are my friends here who are also making a lot of animations like Pavan and Pranesh. They'll also be sharing their views. So this is the future, my dear friends, where we'll be sharing complex topics in a single minute. So less is more, I would like to say. So moving on to the angle animations, where you can see the iris process here, the ciliary body which is slightly pigmented, the scleral spur, trabeculum meshwork pigmented, trabeculum meshwork non-pigmented, and the Schwalbe's line. Once we show the animation, now we take them into the clinical video. This is called metaphorical conceptual learning as I have devised it. So now when we take them like that, we orient them into the animations in a much better way. So it's more like a cognitive match the following. So you can just match the following and you can orient yourself in a clinical frontier. Slowly you can see we take them from iris process into PAS, because at the beginning, what is an iris process? What is a peripheral anterior synechiae? These are some things which confuse a neophyte. So we show animations of the iris process, then we show animations of the peripheral anterior synechiae here, and then we take them into real time scenarios where we play the iris process. This is how the iris process looks, and then we show them this is how the peripheral anterior synechiae looks. So this is more like a metaphorical conceptual learning, like cognitive match the following at the beginning of their curriculum. So then these are some pupillary block mechanism where the posterior iris is in contact with the anterior lens surface, and then we show how the aqueous is not able to get its flow through this area and the angle closure happens. I'll just play this animation once again. So these are some basic concepts which we are trying to make sure we cover through animations. So animative learning will make us understand, okay, this is what pupillary block is and this is how the angle is getting closed. So we'll be doing a PI to actually prevent this. So this will make learning more easier and more fun. So initially I started with Adobe Flash version CS5, costs around approximately 2500 is what my animation toolbox is. So just like drawing a simple square or a simple oval. So you just choose a simple square here. So I first draw a square. So once you draw a square, you can just scale it on any axis you want and make it into a rectangle. So once you have made the rectangle, now for example, the rectangle is at 37 degrees in the first frame. So at ending, we have a frame 20. So in frame 20, it is in a different axis. So the software automatically can move it from one frame to another by having its own way, or you can choose your frame 1 to frame 20 on your own. So in the end, you'll have a product like this, which is moving from point A to point B. So in ophthalmology, what we started doing was we started taking reference images. So take a reference image and you can create your own imaging canvas by giving a color to it, a yellow color, a orange color for the choroid, and for white for a sclera. You can choose your color layering, and once you have created your own ophthalmic cross section, it can be done by that, or you can draw two circles and you can erase these blue arrow areas and you'll get the cross section of the eye. So this is one of my patient who had ICL and he was diagnosed with secondary angle closure glaucoma, and PA was done, but still there was no improvement. When he came to us for second opinion, it was actually a open angle glaucoma which was quite pigmented. So we re-diagnosed him to open angle glaucoma. Yeah, because he had a normal anterior chamber depth, angles were open, there was good ICL vaulting. So we wanted to show him how it really happened in his eye. We showed that once your iris, the pupil got dilated, the ICL was placed. Maybe in the surgery, there could have been a slight rotation of the ICL, and it could have caused the pigment dispersion to actually take place in the first instant. So, creating an animation can work wonders in counseling, as well as these mechanism to understand the pigment dispersion in this rare case of ICL can actually be thought for neophytes as well, for fellows, neophytes, or for counseling material too. So, how did we go about creating this animation? You can see here drawing simple circles with a hole in the center for sclera, then adding the blue cornea, adding the vessels for the conjunctiva, and then adding an ICL behind. So, this is just a scientific screenplay and more like a flip book where you have one above the other. So when you have one above the other, it's more like a flip book. It's more of a flip that you see that the animation is actually moving. It just images, but it set the ball rolling. So how did we dilate the pupil? Simple dilatation of the pupil can be done by actually enhancing the circle size. So you have drawn a circle. So once you have drawn a circle, that means it's a small circle now. The pupil is constricted. At the end frame, you'll draw a larger circle. It is done by using a tool called the motion tween here. So it's just like drawing a simple circle and enlarging the circle. So in frame 1, you'll have a smaller circle, and in frame 80, that is the last frame, we'll be having a much bigger circle. So from frame 1 to frame 80, the circle enlarges in size, giving the illusion of dilatation. Similarly, we add the ICL implants. As you can see here, the ICL is now added, and then the same mechanism is operated on the multiple levels of this particular layer. Even if you want to zoom one particular area and show how the pigment dispersion happened in the first place, we can zoom without it getting pixelated because it's a vector based animation software. Then for adding these pigments, every layer is for the pigment. For every pigment, we had a single layer. So each pigment was set into moving independently. So now let us see the final product. So the circle enlarges, giving you the illusion of dilatation. And now the ICL comes and it gets implanted. At the similar time, you can see that there is a cross section here which shows how the rubbing is starting to take place, maybe intraoperatively or in the early postoperative period. So then you can see the pigment, each pigment in different layers is set into moving, and how it causes the secondary open angle glaucoma in this case. So this is how we can make concept complex very simple. If you have 5 frames between point A to point B, you can move it quite faster. But if you have 10 frames in between the same point A to point B, it takes a long time to move. So these are some simple tricks that you can actually learn in your PowerPoint, which next Dr. Pavan will be trying to cover. So and Prithvi also and Pranesh will also be covering. So to have laser animations here, you can see that SLT procedures like SLT and ALT can be shown in simple animations where the spot size need not be mucked up like people who are having their post graduation. They can be shown where the spot is placed between the pigmented trabecular meshwork and the non-pigmented trabecular meshwork. In SLT, obviously, the spot size is much bigger than the ALT spot size. So all these simple animations and the argon laser peripheral iridoplasty. So this is an eye with normal angle. We show the normal angle first, and then we show how how the oppositional angles are. So now we can see that this is an oppositional angle. The angles are opposed. So now we are treating this patient with argon laser peripheral iridoplasty. The laser spot comes, and now you can see it opens up. It does a plasty here, the thermal energy. So it opens up. So we can show these kind of simple animations. So how the laser is hitting, and then you can see it opening up. So this can also be shown from a front on view. How the 24 spots in argon laser peripheral iridoplasty is placed over the 360-degree areas. So first we showed a gonioscopic a side angle view, then we showed a front on view, then we show the gonioscopic view of the same argon laser peripheral iridoplasty, how it actually helps in releasing the oppositional angle closure by giving the laser at this particular area. So by this, we can give them a holistic coverage of these concepts, which are very difficult to teach for neophytes. Then we innovated this particular application IMG3D. I have shared the QR code with you all in my handouts. So in this app, what we started doing was, more the animations we started to create, the more we felt we need to move into unanimations, because animations is for undergraduates or for neophytes who are actually coming into ophthalmology. But who are practicing people, we felt unanimations with real time true color confocal images in 3D will give you a much better area. So we no financial disclosure, but we have given it free of cost. And this is a QR code. It's available in Android. It is developing for iPhone. We have used wide field 110-degree true color fundus images. And for the anterior segment, we have used real gonioscopic structures and slit lamp images. And we use the software Maya LT and Blender to create the 3D models. Not only we stopped with ophthalmology, we started creating neuro-ophthalmic structures as well, such as the cavernous sinus, the circle of Willis, any structure that is undissectable during our anatomy cadaveric cadavers. These are structures which we don't dissect. So we felt okay, these are structures which we can work on, and we can create the 3D effect for good dissectable learning, which can serve as simulations as well. So we started creating this app IMG3D. And then what we did is we placed multiple cameras inside the software, and for every camera we gave a button, so you can choose which frame you want. Most of the apps today are very static. You click, it moves like a flip book. It doesn't go dynamic. But the application that we created, IMG3D, you can see once you click the button, the eyeball comes and it gives you an option. Every option is actually a camera that we have placed inside the eye. You click anatomy, automatically the eye goes into the anatomical part, and now you are going to click the anterior segment, so it goes into the anterior segment view. Now you can click angle or ciliary body. If you click angle, you will get the gonioscopic view. Now when you click trabecular meshwork, you get the electron microscopic view. So we wanted to give you as much dynamicity as possible. And now you go to posterior segment, and these are all real images, my dear friends, what we have taken from the patient. You can on and off the vitreous, you can choose fovea, you can choose optic disc. If you choose fovea, it goes into the fovea. So I'm just orienting you with the normal fundus here, and you can have the optic disc. Now, once the normal structures are shown, we started adding all the patients' pathology as well. Now, giving a quick glimpse on the pathology. For example, this is a pathological box. You can off the vitreous to for better clarity. You're choosing flecked retina. There is a colored image along with autofluorescence and infrared in the application that we have given. So you have a better view of all the pathologies, especially for neophytes, retinal nerve fiber layer defects in infrared as well. We are given a complete atlas: glaucoma, myelinated nerve fibers, splinter hemorrhages, and this serves as a pedagogical transformation for e-ophthalmic learning as well as counseling. Simple YAG PI, anti-VEGF injections. Patient may tend to ask, why do you need to do a laser for me for YAG PI? We can show these kind of simple animative videos, and we can tell this is why we want to do a laser. This is why we want to do an anti-VEGF injection for you. To a complex surgery can be counseled with this app. So I feel 3D and 4D metaphorical conceptual learning along with these e-counseling stations are going to be the future of e-ophthalmology. And with that, again, I am just ending this part of my presentation with my YouTube channel. Please do visit my channel and please do give your feedback. It is only with the feedback that we are able to develop these kind of applications and much more. So that is my first part of the talk that I wanted to cover today. It's on animations, 2D and 3D animations. Thank you for your time. Thank